Thanks again. Those were fantastic talks. Really enjoyed those. Next, we're going to get into podiatry. We've already heard from some podiatrists, but we're going to get into a kind of a focus session on podiatry. We've got a number of speakers from all over in this section. We'll start off with Alan Block. Dr. Block will be talking about the state-of-the-art techniques in podiatric care. Dr. Block lives in Columbus, Ohio. He started the Columbus Podiatry and Surgical Practice in August of 2015. He's a nationally recognized expert on podiatry treatment and amputation prevention and peripheral arterial disease. He serves as a keynote speaker around the country in multiple conferences, when we actually do have conferences. And his lectures are really unparalleled. Dr. Block, he's an advisor on the Medical Advisory Board at Kent State University, editor-in-chief of the Journal of the American Society of Podiatric Surgeons, and past president of the Ohio Foot and Ankle Medical Association. We'll follow that with a discussion by Dr. Shelley Brand. Dr. Brand will talk about common foot problems, and Dr. Brand practices here in Chattanooga, mostly in Hickson. She specializes in diabetic limb salvage, reconstructive foot and ankle surgery, and peripheral nerve surgery. She trained under Dr. Jorge Matuk and Dr. Samuel Mendocino through the Greater Texas Education Foundation, and she graduated from Kingwood Medical Center. And Dr. Maria Pacheco, will discuss afterwards pitfalls of diabetic wounds, avoiding disasters. We talked briefly earlier about diabetic wounds, but Dr. Pacheco will expand on that quite a bit. She graduated from Barry University School of Podiatric Medicine, completed a 3-year residency in reconstructive foot and ankle, residency training program at the JFK Medical Center in Boynton Beach, Florida. Her focus is on forefoot reconstruction, including bunions and hammer toes, diabetic wound care, and limb salvage and reconstructive surgery of the rear foot and ankle. Dr. Pacheco is bilingual and on staff at Hamilton County Medical Center, Hamilton Medical Center in Dalton, Georgia, as well as Park Ridge Medical Center and CHI Memorial. Lastly, we'll have a really cool multidisciplinary panel discussion between Chris Lassar, who you met earlier, as well as Dr. Shelley Brand, Dr. Aaron Solomon, who is a podiatrist practicing here in town. He originates from Temple University School of Podiatric Medicine in Philadelphia, Pennsylvania. He completed a medicine and surgical residency at the Montgomery Hospital and Medical Center in Norristown, Pennsylvania, as well as completing an additional year of residency in advanced foot and ankle reconstructive surgery in Austell, Georgia. He's board certified by the American Board of Foot and Ankle Surgery, and a member of the board of directors and a fellow of the American Society of Podiatric Surgeons. He's also on staff at Hamilton Medical Center, as well as CHI Memorial, as well as Park Ridge. And lastly, joining that panel discussion will be Dr. Sam Bazarafsham. Dr. Bazarafsham was raised in Knoxville and attended the University of Tennessee, earning a degree in psychology of all things. He attended Barry University School of Podiatric Medicine and Surgery, and participated in clerkships all across the nation, including Yale and Highlands Presbyterian in Denver. He has extensive training in all areas of foot, ankle, and lower leg surgery, and he's associated with the American College of Foot and Ankle Surgery, the American Podiatric Medical Association, and the American Society of Podiatric Surgeons, and he too practices here in Chattanooga, Tennessee. So with that, I'll turn it over.
Good afternoon, I'm Alan Block, and we're going to be talking about the PAD patient and ways to treat them. So very, very simply, we know that peripheral vascular disease has been around forever. And in the 1800s, we cut off your leg and you either died of sepsis or you died of blood loss. But we've had 200 years to perfect this. We've gotten better as physicians, we've gotten better instrumentation, we've gotten better referral networks. But in the year 2020, we're cutting off over 180,000 legs a year. So we're not doing really well, and it's probably because we're living longer and we're living sicker. It turns out that in 2005, Ali did a study and found out that less than 50% of the patients who had an amputation had any kind of vascular workup, which was despicable. In 2012, he followed that up with looking at 20,000 Medicare patients who received an amputation, and it was noted that less than 54% did not receive any vascular procedure, including a diagnostic angiogram before amputation. And this, in my mind, should be considered criminal. And it turns out these people are not thinking that well. We know cognitive processes impair as you get older, and especially in diabetics. And if you put the two together, we know that's a bigger problem. We also know that diabetics who have cognitive impairment are more likely to have ulcers on their feet as well, which goes to the problem. And when you take a look, the cost of treating the diabetic foot ulcer is greater than the 5 most costly forms of cancers. So the diabetic foot ulcer patient is twice as expensive to Medicare as those with just diabetes alone. So it turns out that every 7 seconds, someone dies from diabetes, and every 17 seconds, someone is diagnosed, and every 1.2 seconds, someone develops a diabetic ulcer, and every 20 seconds, someone has an amputation. And eventually that someone becomes close to you. It is someone in your circle, and you will tell stories about it. That comes to 4,320 legs and feet that are lost every day, right? It turns out that 1/3 of patients seeking care for ischemic wounds die with that wound unhealed. And I think a lot of it is poor treatment choices, not getting the patient out to all the specialists and the different treatments they need, because a patient who has a ischemic wound is already dying from the inside. We also know that diabetic foot ulcers double the mortality rate and heart attack risk and increase strokes by 40%. So we know these people, these candidates that they're not good patients. If you take a look at my patient here, this guy has been suffering from an ulcer for 3 years. This is the whole bottom of his heel. He's had multiple amputations of his digits and some of his metatarsals, and he doesn't want to lose this because he wants to be ambulatory. Now, the problem with this is 2 things. He has infection, he has poor vascular flow, and started off by intervening on him or having an intervention. Once the intervention was done, I was able to open his foot and do a flap, also go into the infected bone and put calcium phosphate, the appropriate antibiotic, and then close it up, as you can see, with the skin flap. And I thought he was doing really well, and he was. And about 1.5 years later, he comes back, and the ulcer is back. This is, again, he needed a second intervention, some antibiotics, as well as, you can see him here on the right today. This is of a week ago. But the point is, these patients need a lot of care. They need a lot more than we can do alone. This 47-year-old male here, he has an A1C of 7.8, 13 months ago, and this is an 18 months. He stepped in a hole, twisted his ankle, went to the hospital, and his x-rays were negative for fracture of his ankle. However, he has a Charcot foot, and this is him at 18 months, but this is him at 13 when I saw him. He had a wound care whole team. He was being treated by multiple specialties. His infectious disease doctor saw him and said, hey, if you want to keep this foot, you're going to have to drive about 2.5 hours to Columbus to find me. I did do a bone biopsy and got him on the right antibiotics. He didn't want to have surgery right away. This is his ankle extruding from his leg from the Charcot. This is him at 18 months. And you can see here that we've got this healing, which I've never seen anything like this muffin in my whole life. But my big concern when he came back, the necrotic first metatarsal, that gangrenous plaque that he's developed here, this is my big concern because I want to reconstruct him. Again, he did need a second intervention a little bit later on. Now, this is about a 3.5-year journey for this gentleman. You can see the size of this on the side. And this is after he's been revascularized. You can see the nice hue of the redness and pinkness of the tissue. It's infused. The gangrenous plaque is healing, which is really what I need to see. And after that, I usually wait 3 months or so before going in and beaming or whatever I was going to do to this gentleman, which was a lot. Now, why are so many diabetics? Why are we seeing the lower extremity amputations back on the rise? Well, there's a real big reason for that: the cost of insulin. We find out that patients are not taking smaller doses to expand it because they don't want to spend the money. They're stretching out their supply. They're not filling the prescription. And that brings up a good point. When a new patient comes in and they're there for a diabetic foot ulcer or just diabetes in general, if they don't know what their A1C, and better yet, they don't know about what their glucose was today because they don't take it every day, that's a patient that you need to take under your wing. Because again, as we talked about their cognitives, most of them don't remember what you say. And so it's important to get this patient right, because this is the patient you're going to worry about it. Again, we know what happens when they're not controlling their sugars. So over 30 million people in the United States are diabetic. We know that 90 million are pre-diabetics. That number has gone up. But the patients who are pre-diabetics are already on metformins and drugs. Nobody's told them they're diabetic. They're still hanging on to the pre-diabetic, right? But we know by 2050, 1 in 3 of us will be diabetic. That means if your child was born in the year 2000 or above, your chance of that child being diabetic is 33%. 11% of the total healthcare expenditure is being spent on these on diabetes and these ulcers. So when we look at ABIs, and I find ABIs insulting because they're taking an ABI at the level of my job stops, essentially. And an ABI is a good indicator of poor flow. But if you did TBIs and TCPO2s and things like that, you would find vascular disease at a much earlier state. And my feeling is the earlier we treat this disease, the better. And this bears it out. The ABI of 1 is normal. And anything below that is abnormal. And looking and saying, it's 0.9, it's 0.8, it's okay. At what point do we stop and say we need to intervene on this patient? We need to intervene sooner rather than later. If you watch this gentleman's right leg here, he fractures it, as you can see. And of course, we're all appalled. But we should be just as appalled by the patient with the chronic injury, the chronic wound that's not healing, right? We should really understand that because these patients have become comfortable with that wound. And sometimes they've named it. They have a pet. They have a routine. And once it becomes comfortable, and the most dangerous word in the English language is comfortable to me, they stop thinking they have to do anything. They just think they have to live with it. And that's where we have to stop it. So an open wound is loss of tissue, and we know that. So when we look at it, we have 180,000 amputations taking place in the United States per year. 25% of the time, a lifetime, a diabetic will lose some part of their leg or foot. And 30 days preoperative mortality for a BKA is 8 to 12%. And an above knee amputation, 10 to 15% of these patients will die. 24 months overall mortality is somewhere between 40 and 50%. So amputations are not benign. Now, this is my patient in 2006, the first patient that I had intervened on who was he had one vessel runoff below the knee. And the problem with that, he had enough circulation to maintain the ulcer, but not enough to heal it. So you need that blood flow. You need that energy to actually heal it. We know that. It's a lot more energy than just maintaining it. In 2006, the instrumentation got better. The doctors who I use were getting much better at their skill set, and they were going below the knee. And when they started to open up that second vessel below the knee, life changed for me. Patients who I could not heal, that I could just maintain, started to heal. And that made all the difference in the world, right? If you look, over 8% of the population of the United States is type 2 diabetic, and over 5% of the population of India is type 2 diabetic, and over 7% of the population of China is type 2 diabetic. 1 in 400 children and adolescents in the United States are not only diabetic type 1, they are becoming obese, so much so that the CDC now tells us these children are developing non-cirrhotic fatty tumors in their liver in such a way that by the time these children hit 35 years old, we need 5 times the liver transplants that are going on right now. So when you look at this and you talk about the Mediterranean diet, they sent Michelangelo's David over here to spend a year. And after living on the American diet for a year, this is what he looks like. So when we go on, how do you treat this disease? You treat this disease by inventing technology and understanding the technology, and by treating the pathology that comes along with it. So you start to treat that pathology, but you must change the psychology of not the patient, but of the treating doctors. You must tell the world what we have, what we can do. And you do that by using everyone, the specialists, engaging the family doctor, engaging the podiatrist, the nurse practitioner, the family doctor, every specialist, the endocrinologist, everybody who needs it. You must disseminate the information. You must tell them that this exists. Now, my favorite thing is not EMR, because I can write till I'm blue in the fingers with EMR, but I will tell you, the best thing I have is my telephone. It is having that telephone number of that vascular specialist, that interventionist, who can actually save my patient's life, and getting on the phone. And I know when they call me, I spend special attention to their patient. And I certainly know they'll do it to mine, because when I call, they immediately get the patient in, which is critical. You need that lifeline, not just for yourself, but for the patient. So when you look here, I'm at a football game and this guy takes off his shirt. And of course, I stop watching the football game, right? I'm like thinking an esthetician, maybe some wax, maybe shaving. But why we do this, I stopped watching the game. And this goes to what Larry Harkless says. And he says, you see what you look for and you recognize what you know. If you start to look for peripheral arterial disease, if you start to look for it, you will recognize it. And because you recognize it, we now have pathways to treat it. And that makes the difference, knowing we have ways to treat this. So you talk about this, the independent calcium prediction values. Now, we know a lot of these patients are calcium formers. When you have an ABI of greater than 1.3, that means that patient has formed calcium. And that's important because critical limb ischemia is 0.4. And that's the patient with an ABI of 1.3 where the calcium grew and now they have great blockage. So the time to treat this patient is when they're 1.3, not when it's critical limb ischemia. They do much better, right? And you have a much better chance of getting through an artery that has less blockage. Diabetes, especially in the present neuropathy, present for 12 years or more, calcium former. Again, when you take an x-ray and you see calcium on the forefoot, now this is that patient you palpate and they sound to have a great pulse, yet they're not getting better, right? They're ischemic. And my question comes down to when the vessel ossifies, is it osmotically, is it able to get the blood out from the vessel into the surrounding tissues? And it's a good question to ask. Again, history of tobacco use, we know that. Creatinine of greater than 1.7 or a GFR of less than 60, these patients are calcium formers. And it's a good thing to know. It's a good thing, especially if you're sending them on to a vascular interventionalist. Only 31% of wounds heal within 20 weeks, and we know that. 85% of amputations of the foot are preceded by an ulcer of the foot. 80% of hospital admissions for diabetics are for infected foot ulcers, the number one reason. And the old adage is, very, very simply, it hasn't changed, half the size in 4 weeks. Because it turns out that calcium equals critical limb ischemia equals amputation. We know that. The studies all bear that out. And it's recognizing it, it's early intervention on these patients, it's changing their lifestyle, it's getting them out of that comfort zone that they think they're in. But the first thing that I do in any of my patients who have any kind of wounds, and especially if they've had it for any length of time, is restore the flow. So my first thing is I send them out to a vascular lab. And the reason I do that is the vascular lab usually has a connection to the vascular specialist I want. And most of my patients, because it doesn't matter how good the wound care material I'm using if they don't have the flow to be able to heal the wound. So my first thing is, again, restore the flow. This is my favorite patient to talk about. She's 83 years old. She has non-healing wound, tissue loss, it's gangrenous. She has rest pain. She's a smoker, 3 packs a day. She drinks 2 to 2.5 highballs a day. She has a left ABI 0.4, and she has a stent in a renal artery. And she's she's probably one of the meanest patients I have, and I've told the story many times. She comes in this particular day, and my office staff is not particularly fond of her, and I'm usually buying lunch that day. It's that kind of patient where you sit outside the room and you walk back and forth before you go in. On this day, I go in, and if you see the U of her foot, you can see that that's not just a 4th toe that's gangrenous. That is a foot that has really poor circulation, and she probably won't heal just taking off the 4th toe, and she's probably looking more like a below-knee amputation. On this day, she says to me, Dr. Block, can you save it? And I say, yes, in a box. And she doesn't think I'm funny. I send her the only thing I know what to do, and that's to go and get her to the vascular specialist. In this case, if you look here, you can see that somewhere up here, there's no femoral artery, but there's a lot of collateral circulation. However, as you come down here, you start to see the stem of the distal femoral artery, and very, very simply, you can see that it's completely blocked. So very simply, they did an intervention on her, and you can see 2 things. One is you can see the patency now of the femoral artery. You can see the femoral artery as they opened it up. And you can see that the collateral circulation has disappeared because you've opened the main flow. This is healing. This is what patients and all of us live for. If you take a look here, this is that patient when she came in. After 2 months of this being intervened on, she would come in and I would simply ride down that little black gangrenous plaque, and about 2 months into it, it falls off and there's this beautiful pink 4th toe. And for the first time of knowing this patient, she smiles. She lives in a retirement village, not a nursing home, and she goes back to them and she tells everyone there that Dr. Block grew her a new toe. And not a joke, my phone starts to ring off the hook. And here's why. Patients are calling me because they think that if I put my hands on them, they're going to heal, right? They think there's magic in these hands. And I let them come in because I knew the offices, but they want me to, they have headaches or shoulder pain or knee pain, and I'm a podiatrist, right? So the big thing here to understand is this was not magic. This was just utilizing all the specialists we have. And that's what really made the big difference. If you take a look here, and my final slide is this. I've read two articles out of vascular surgery, 2 out of interventional cardiology, and 2 out of interventional radiology. And the important part is this. All articles say if you open up one vessel, they can probably maintain the ulcer. You open up 2, they'll start to heal. And if you can open up all 3, that patient can maintain a normal lifestyle. So when I'm looking at the ABI here, I don't try to explain to my patient waveforms. It's not what I want to do. What I do is explain to them this is the heartbeat of the leg. And when this is flat, that leg is dead. Now, I want to tell you something. What I realized, I was sitting with a group of vascular surgeons one day after we had watched 5 interventions. And they were saying to me, gee, Dr. Block, there's not one patient here that we would have intervened on because our number one issue or for intervention is pain. I said, well, that's really interesting. My patient's neuropathic. They can't tell me about pain. And it led to this. We as physicians and healthcare professionals can no longer afford to be deaf to a patient who is mute. And I thank you for your time. Feel free to ask me any questions. If you want to email me, there's my email address. And again, I thank you for your time, and I hope you enjoy the conference.
Hello, my name is Dr. Shelley Brand. I am a podiatrist at Village Podiatry in Hickson. Today, I'm going to be going over some common foot problems in diabetic patients. I deal with a lot of diabetic patients in my office, and I feel that the best way to go over all of the complex issues that we address here is to go through a podiatry-focused exam and go over some of these areas that are very at risk for breakdown with these patients. We'll start off by going over a vascular exam that we do in the office. Typically, this involves a look, listen, and feel approach where we look for changes in the skin, nails, any diminished hair growth. We listen to any subjective complaints, including cramping to the legs, whether that's when they're resting or when they're walking around. We also feel for pulses, check the capillary refill time, assess the skin temperature, and then look at it whether there's any edema present, whether it's pitting or non-pitting. If there is any issues that we find on the physical exam, it typically warrants a vascular referral. And it is important to make sure that we assess these patients not only through their diabetes, but whether or not they have any history of smoking, if they have cardiac disease, or any history of stroke, because this is important to understand what may be going on in the legs and the feet as well. In regards to do therapy in the office, typically with Una boots, and progress into compression therapy with compression socks or stockings. However, we do need to make sure that the patient has adequate blood flow before we get started with any type of compression in the office. The next component is the neurologic exam. This involves subjective findings, asking the patient if they've experienced any numbness, burning, tingling, pain in the feet, if they have any loss of sensation to any parts of the foot. We also check for physical exam findings with the Sims-Weinstein monofilament test and the vibratory sensation with the 128 millihertz tuning fork. And these can help detect early signs of neuropathy even before it becomes to the point that the patient's aware that they have lack of sensation. It's also important to look at any loss of deep tendon reflexes as well. And diabetes is usually the most common thing that we'll see that is the reason for the neuropathy in the feet. However, there is other issues. Alcohol abuse and chemotherapy are also common. Unfortunately, for these patients with nerve damage, there's no cure for it, and oftentimes it's management of the symptoms. And if there's pain, sometimes we do have to place the patients on gabapentin or Lyrica. But it is important for the patient to understand that good glucose control is important to prevent the progression of the neuropathy. It's also important to explain to the patient why neuropathy is a dangerous situation, because if they aren't able to feel what's going on the bottom of the feet, they may be walking around barefoot in their house and step on something and have no knowledge of it, and it can progress to the point where it's now a limb-threatening situation, when if they were able to just look at their feet once a day, they would have been able to catch that sooner and prevent limb loss. The next component of the exam is the musculoskeletal. We look for any range of motion issues, any foot deformities that would put the patient at risk of having these areas overloaded and creating tissue damage to these spots. Oftentimes we have range of motion diminished with neuropathy, whether that's through equinus, where we have loss of the Achilles function, or through arthritic damage to the foot and ankle that can lead to areas of increased pressure just because they're not able to get the adequate range of motion. The other thing we look for are any foot deformities, whether that's bunions, hammer toes, flat foot. Charcot is another important thing that we have to assess for in diabetic patients, because early signs is just a red hot swollen foot, and if we can get them offloaded, we can help prevent the collapse of the midfoot and prevent those bony deformities developing on the plantar surface. Charcot is very dangerous because it leads to a completely new weight-bearing surface on the bottom to these areas that are not designed for the pressure in those areas. And so it's important for us to assess for these type of deformities. The other thing that we also have to look for is any previous amputations, because when you have an amputation, it leads to a new biomechanic function of the foot. And so these new deformities that can develop because of the previous amputations need to be documented and addressed with offloading and sometimes even surgical procedures. In regards to neuropathy, for these diabetic patients with loss of sensation, we have to check and make sure that these bone deformities don't progress, because neuropathy will affect the intrinsic muscles to the feet, and that leads to progression of these deformities and puts more pressure on these bony prominences and leads to tissue breakdown sooner than somebody without neuropathy or diabetes. It's also important to determine if they had any genetic component to the foot, whether they've had a bunion, flat foot, and also obesity is important to look for, because that puts increased weight to these small joints to the feet and leads to further breakdown as well. Oftentimes, as much as we can for the diabetic patients, we try and do conservative as much as we can through offloading, shoes, orthotics, bracing, and boots. When that fails, that's usually when we have to intervene with surgical procedures, whether that's bone or soft tissue, whether it's through osteotomies, fusions, tendon transfers, or releases to give them a plantigrade foot that's not going to break down, because if not, then that leads to amputations. The final component is the dermatologic exam. It's important for us to assess the skin barrier, because this is the protection to prevent bacteria and fungus to get into the skin. Unfortunately, in these diabetic patients, there's a lot of different things that can go wrong in the feet and the nails. Most commonly, we deal with toenail fungus in the diabetic patients. If it's treated early enough with antifungal medicine, oftentimes we can prevent the progression of these thick dystrophic toenails. Unfortunately, oftentimes these patients come in and their nails are significantly elongated. And the issue that comes with that is that it can create crowding to the shoe. that leads to increased increased risk of tissue breakdown at these bony deformities in their shoe, and it can lead to nail bed ulcers if left untreated. The other thing that we deal with very commonly is ingrown toenails. And if it's somebody that we can, if they have good vascular situation, we can typically address these in the office. The issue becomes when you have a diabetic patient that has no sensation, these ingrown toenails get overlooked and progress into severe infections that can lead to amputation of the toe. If unfortunately we could have caught it sooner and addressed it. The other issue is if these ingrown procedures are done on somebody with lack of good blood flow, it can progress into gangrene very quickly. So it is important to assess the vascular status before we do any invasive ingrown procedures as well. Calluses are very important in regards to my diabetic patients. I make sure that they're all aware that calluses are what turn into ulcers. An ulcer doesn't just appear out of nowhere. Usually there's a reason behind it. And for these diabetic patients, if they have all these bony deformities and prominences on the feet, your body tries to protect those areas by laying down callus. Unfortunately, in a diabetic patient that has no feeling, these progress to the point where the buildup of this tissue has nowhere else to go but back into the skin, and it opens up and leads to ulcers and infections. So it's important to look at the bottom of the feet and in between the toes to look if there's any corns, calluses, or buildup that needs to be addressed. The other portion is the skin. We need to make sure that it's well moisturized. We have to look for any skin fissures or xerotic skin. And this is important not necessarily from a cosmetic standpoint. And I explain that to the patients that I care more about well moisturized skin because that disruption in the skin barrier is what leads to infections, cellulitis, athlete's foot, things like that. Because there is now an opening to that skin barrier from that dry, cracked skin. It's also very important to look if there's any interdigital maceration because athlete's foot in between the toes can lead to abscess formation and deeper infection if not treated appropriately because that macerated skin becomes very friable and opens up and allows for infection to get in. We also have to check if there's any fluctuance or abscess formation under the skin, and if we need to send them to the hospital for IND or amputation and antibiotics as needed. And then the final part of the dermatologic exam is checking for ulcers. Most commonly, we deal with the diabetic ulcers on the plantar surface of the foot, and those are treated with debridement and wound care. But we also have to check for any pressure sores or venous or arterial ulcers as well. And this is where a team approach with the vascular surgeons, with the wound care centers in town, primary care and infectious disease, because these ulcers are typically not something that we can just treat very quickly. These take time, and it takes a team approach from all the different services with wound care and things like that to help get these patients to heal and prevent loss of limb. The final thing that we do in the office for our diabetic patients is routine care. The better that we can prevent these problems from happening, the better chance that we have at saving their limb and ultimately saving their life. So we do routine nail and callus care. We do diabetic shoes. And honestly, the best thing that we can do is educate our patients on what to look for and prevent these issues from progressing to the point that they have no other option but a below knee or even above knee amputation. Thank you.
Hi, my name is Maria Pacheco. I'm part of Village Podiatry, and my topic of discussion is pitfalls of diabetic foot wounds, how to avoid disasters. Diabetic foot ulcerations will occur in approximately 25% of diabetics. More than 50% of these diabetic foot ulcerations will return in approximately 3 years. 86% of lower limb amputations are preceded by foot ulcerations. The most common causes of diabetic foot ulcerations include diabetic peripheral neuropathy, Charcot-neuroarthropathy, partial foot amputations, particularly of the first ray and fifth ray, biomechanical abnormalities, and of course, peripheral vascular disease. Pitfalls of diabetic foot ulcerations occur when we avoid using a multidisciplinary approach, identifying peripheral vascular disease in these very high-risk individuals, avoiding immediate referral to wound care specialists, vascular specialists, etc., neglecting to offload these ulcerations, microbiology errors when obtaining cultures, wound care techniques, and surgical correction. Using a multidisciplinary approach starts with the initial assessment. A lot of the times these initial assessments will present either to a primary care physician office or to our podiatric offices. So routine podiatric and wound care assessment is essentially important. Appropriately performing a neurological workup to assess motor, sensory, and autonomic neuroarthropathy is the most important part of our assessment. Obtaining relevant culture data, performing wound assessment, staging, grading of the ulcerations, and making sure that we lead with culture-specific antibiotic therapy. Classifying ulcerations according to size, depth, and presence and presentation of the ulceration is important in order to transfer this information to our colleagues. Properly offloading is vital for these neuropathic lesions, whether it's by cam walker, total contact casting, or forefoot wedge, which we'll discuss in next few slides. Anytime a deep infection is seen, obviously it requires immediate drainage. Using a multidisciplinary approach can start off with the primary care physician who essentially sends out the referrals, followed by vascular evaluation to assess for peripheral arterial disease, and endocrinologist, which controls glycemic control. A study showed that a reduction in A1C by 1% was associated with a 43% reduction in the risk of amputation or death from peripheral arterial disease. Infectious disease specialist and infection management is of vital importance when dealing with either acute infections or underlying osteomyelitis. Vascular status cannot be overlooked. Research has shown that diabetes is associated with a 2 to 4-fold increase in the incidence of peripheral arterial disease. The estimated prevalence of a purely ischemic wound is approximately 15%, whereas by the prevalence of a neuroischemic wound is about 50%. In a 2004 study, publication in the IDSA-DFI guidelines show that many foot infections are treated inappropriately, including failure to address underlying conditions such as peripheral arterial disease. A 2010 study showed that 291 patients were evaluated, assessed, and hospitalized for diabetic foot wounds. However, PAD was associated with the poorest of the outcomes, and researchers noted that for the most part, it went unaddressed by treating clinicians. This is a pretty busy slide, but it's knowing when to refer to podiatry or vascular specialists. It categorizes patients under an ADA risk category, with an urgent risk category involving the indications of open wound or ulcerative area with or without signs of clinical infection, new neuropathic pain or pain at rest, vascular compromise, meaning sudden absence of DP and posterior tibial pulses, or gangrene. The timeline of the referral is immediate for these patients, and then follow-up is determined per specialist. And ADA risk of 1 would be loss of protective sensation, non-changing deformity, patient requiring prescriptive or accommodative footwear such as custom diabetic shoes. Typical referral is approximately 1 month, and then follow-up is usually anywhere between 3 to 6 months for these patients. This is a busy slide, but the gist of this slide is to show the pitfalls that can occur when obtaining wound care samples. Clinician-related issues involve when we rely on culture results while the patient is already on antimicrobial therapy. This can result in incorrect use of antimicrobial antibiotics and inappropriate growth or inaccurate growth of certain bacteria. Use of superficial swabs can often lead to false positive culture results treatment with too broad spectrum antibiotics. In these cases, a way to avoid or evade these pitfalls would be to use tissue biopsy for sampling. Something newer in the podiatry realm is PCR and other genotypic analysis. Unfortunately, these analyses can give false positive results and treatment with too broad spectrum antibiotics because typically these will identify non-pathogenic organisms. It can pick up flora, and therefore we are treating these simply colonizing bacteria versus infectious. A major factor in recurrent ulcerations is not using proper offloading techniques. A major biomechanical factor in causation of foot ulcerations is elevated peak plantar pressures. Of the 29 patients in a recent study in category A treated with total contact casting involving a total of 39 foot ulcers, it showed that correct offloading with total contact casting led to 36 of the 39 patients to heal their ulcerations, whereas the other category, which simply was topical wet to dry dressings, no offloading techniques, only resulted in 25 out of the 39 ulcerations healing. This study showed that total contact casting or even fixed ankle walking boots meet the standard for relieving pressure on the sole or the bottom of the foot by at least 30%, which can result in saving a limb. Another wound technique is to consider negative pressure therapy when appropriate, knowing when to use it. More than 300 articles have been published on negative pressure wound therapy. It seems to be a safe and effective treatment for complex diabetic foot wounds and technically can lead to a higher portion of healed wounds at a faster rate and potentially fewer reamputations in standard care. A greater portion of foot ulcerations achieve complete closure in a recent study when compared to Amerigel wet to dry dressings. 73 of the 169 patients studied healed their ulcerations within a 112-day active treatment phase period versus Amerigel wet to dry, which only resulted in a 28.9% healing rate. Thereby showing that wound vac therapy experiences significantly fewer secondary amputations when compared to standard Amerigel wet to dry. Not using biologics is another pitfall. Knowing when to use biologics is something that can save potentially a limb. Biologics should be considered after patients have exhausted conservative care within a 4-week period. Used in combination, of course, with standard care measures, including debridement, moist wound healing, offloading, negative pressure therapy when indicated, and infection management. In a recent study, wounds treated with biologics actually showed a 31.2% more likely to heal than wounds first treated with topical recombinant growth factor and PRP. And that was 40% respectively. Advanced biologic therapies were used on average within 1 month and improved healing of refractory diabetic foot ulcerations. Our final pitfall is knowing when to use surgical management of wounds. This can be in office or in an OR setting, where the first line of treatment is excisional debridement. By excisionally debriding ulcerations, we're surgically decreasing the bioburden of bacteria and removing devitalized tissue, promoting good granular tissue and healthy growth of new tissue. Surgical management can also include correcting the underlying foot deformities, most commonly exostosis, accessory bones that can lead to plantar ulcerations of the hallux, Charcot arthropathy with prominent talonavicular bony prominences. TMAs with tendo-Achilles lengthening can prevent recurrence of ulcerations, particularly of the forefoot incision sites. Knowing when to use skin grafting. It's relatively simple, reliable, and effective technique for the closure of diabetic foot ulcerations, particularly when used at the right setting with the right indicative patients. Local skin flaps, intrinsic muscles, local random and or pedicle flaps provide other options for extensive wounds of the diabetic foot. And unfortunately, as much as we do try to avoid amputations, sometimes with an underlying osteomyelitic patient, severe loss of viable tissue, we do result in amputation, but we try to keep it at a lower degree or a lesser digital amputation to prevent any major lower extremity amputations. In conclusion, avoid pitfalls by using a multidisciplinary approach, identifying patients with vascular compromise, and make sure that these patients are being referred for vascular workup. Refer to wound care specialists and podiatrists as soon as possible, using proper offloading devices, obtaining appropriate microbiology samples using a good technique, and using adequate wound care techniques when appropriate. Surgical correction is always useful in the appropriate setting once conservative measures have failed. These are my references, and I appreciate your time.
Welcome back to the Faces of PAD, and we're going to be talking today with my esteemed colleagues on the multidisciplinary approach for limb preservation. I'm Chris Lassar, and in the order going down is Shelley Brand, Podiatry, and next is Sam Bazrafshan, Podiatry, and Dr. Aaron Solomon, Podiatry. So the four of us are going to talk about how we approach some of these complex problems, and we're going to start off with a doozy with Dr. Solomon talking about this case.
Well, this gentleman, it's a 69-year-old diabetic Hispanic male. He had progressive gangrene to the right foot, toes of the foot, and the forefoot. Past medical history includes type 2 diabetes, dyslipidemia, hypertension, AFib. Social history, former smoker, quit for over 20 years. He did have a palpable right femoral pulse, popliteal, and dorsalis pedis, and a non-palpable posterior tibial artery pulse. Here's the clinical presentation of this young man. As you can see, pretty significant gangrene to the right foot. Not only is there concerns of ischemic changes to the right foot, obviously you can see there's also concern that this is starting to abscess. So based on these clinical findings, most importantly the finding not only of ischemia, but more importantly infection, this was an emergent case, and we took this gentleman to the operating room for immediate debridement. Debridement postoperatively, this was a transmetatarsal amputation, as we can see, flap closure. He did have perfusion in the operating room. This is just before we were putting on the postoperative dressing.
Aaron, sometimes when we have vascular patients like this, or patients with these presentations, sometimes it's a vascular first, and sometimes it's podiatry first. Why did podiatry operate first? What was the thought process?
The concern was the abscess formation. Sometimes we, in a perfect world, and we all know it's a perfect world, we like to see these patients, do a clinical examination, do arterial studies, see that this patient has evidence of peripheral arterial disease, consult vascular surgery, have a revascularization done, and then go do our debridement. Sometimes we don't have a choice. If this patient has abscess formation, if they have infection, if it's more severe, if they're septic, if they're toxic, if they're hypotensive, if they have clinical signs of septic shock, this is an emergent case, and debridement has to come first. And yes, there's a risk that doing debridement in the presence of ischemia could result in further ischemia down the road and more debridement. But unfortunately, not only are we dealing with a limb-threatening situation, now we're dealing with a life-threatening situation. So, we always have the saying in podiatry, the sun never sets on pus. And so if we do have an abscess if we do see that this gangrene starting to abscess, it's really important that we proceed with debridement, and then obviously as soon as possible have vascular surgery come in and do the necessary reperfusion.
Right. And so this is where vascular comes in. And in this particular case, 100% agree with your management strategy on this. But I need to do an angiogram as well to prove, even if it's normal, that the circulation is going to be strong enough to heal. And so this is an angiogram of the SFA, which is normal in the lower leg. The popliteal artery looks pretty healthy. Looking at the tibial vessels, we have 3 vessels coming down to the foot. But what we do see is an area of stenosis, and this is in the lateral plantar artery. And what we're worried about is that posterior flap. That posterior flap has to have good circulation to heal. And so we address this lesion here to fix that. He also had the anterior circulation came down pretty well and fed the anterior flap. It seemed to be just fine. Now, this pedal arch, where the arteries normally connect, is out. And my thoughts were to see how we did with this patient, to see if this is going to be adequate, or maybe I would have to go back and do a little bit more. And so this was the stenosis. This is after we did angioplasty, good perfusion to the foot. And so we fixed different areas to improve flow into that flap. So one of the things that we do is we're going to want to know is after we do the therapy, is it enough? Is this perfusion enough? And so we've seen this before. We talked about the anatomy from Jill Somerset of the foot, talked about acceleration times, how we can look at the arteries in the foot and map out exactly the flow in that foot. And what we're looking for is that acceleration time, that slope on the wavefront of the circulation as it moves through. And if it's very vertical, very strong, we know it's going to be good. This is again normal. If it's flattened out and very a lot of turbulence, then that could be a sign of a lesion. And so post-operatively, he had triphasic flows into that foot. His ABI is super therapeutic. It's 1.4. He's a diabetic, so his arteries are calcified, and you'll see that sometimes. But when we look at the acceleration times, they're all basically pretty normal. His class 1 perfusion, rest pain was resolved, and his wound healed at 2 months. So this is what we're left with. So I'd be curious from the panel. At this point, we've gotten him through this disaster. He still has a leg. He can still walk. What do you worry about? What's the next steps in this?
Well, and I'm sure my associates can chime in. And obviously we're concerned about the biomechanics here. Obviously we lost several of the extensors. We have equinus deformity from the Achilles tendon. Now that the Achilles tendon is overpowering basically the extensor tendons that have been lost, and the tibialis anterior is still intact, we sort of developed this sort of equinovarus foot type, where basically we see that there's some plantar flexion of the foot. We see that the foot is turned in a varus position. So our big concern here is, okay, we have good healing. We have a nice plantar grade foot that a patient can walk on, but we don't want them to develop a stump ulceration because there's increased pressure on the end of the stump. Obviously, getting these patients into proper into proper prescription footwear, whether it be a diabetic shoe with a filler or even an ankle foot orthotic, is important. And then also, in some cases, and I'm sure Dr. Bazrafshan and Dr. Brand can allude to is surgical management sometimes of this deformity.
Any thoughts, from the primary care when they see this patient back, and what are the red signs that there's something wrong?
Well, obviously, first and foremost, ulceration, and not just ulceration. It could be simply a callus. Patient comes in with having a previous transmetatarsal amputation, and the primary care physician sees on the end of the stump a callus. It's not an open wound. It's not a sore. There's no drainage or anything. It's just a simple callus. But in our mind as podiatrists, to us that's an ulcer. We'll call it a grade 0 ulcer. There's no opening of the skin. But if left alone, that will become an open wound. And now we're dealing with a more complicated issue. So just seeing something as innocuous and as simple as a callus tunes us into the fact that there's pressure somewhere on this foot that needs to be addressed. Not necessarily surgically. It could be addressed through orthotic management. It could be addressed through bracing. It could be addressed through simple debridement of the hyperkeratotic tissue at the side of the callus. But as long as it's addressed, we can hopefully prevent that skin breakdown and pedal ulceration that can lead to further surgery. And
Sam, if this was your patient, how often would you see him back, and what would you, how would you manage him follow-up wise?
Based on guidelines, we would like to see patients that have had an ulcer or have had an amputation monthly until they are stable. There's no major concern for reulceration or further development of further wounds. And at that point, we would push it out to 2 to 3 months and see them quarterly. But ideally, monthly for any patient that's previously had an ulceration or a amputation.
Shelley, it seemed like that wound was pretty bad. I mean, how long would it take for someone to mummify their toes like that before they come in?
Oh, it can happen it can happen quickly if the disease is that bad. I've seen these progress over even a couple weeks to the point that it just becomes mummified tissue. But catching these early enough and catching it in the office, even in the primary care setting, to where they can just palpate the pulses in a diabetic patient, if we can just catch that before it becomes to the mummified state, that's going to help save this guy's life. And that's something that we can do in the office from our setting with these routine checks, especially for patients that have had previous ulcerations. Now he's also at risk of the other foot breaking down as well.
Gotcha. Well, one of the concerns I had was access to care. He's a Hispanic gentleman, does not speak English. And, I think one of the things is that people just try to avoid, coming in and seeking medical attention. And maybe in this case, it was a language barrier. But again, breaking down the access to care is going to be really important for our marginalized folks to if we're going to promote and achieve limb salvage for these people. So we're going to move on to a second opinion case. This was a patient that was sent to me, a 60-year-old white male presented to the office, gangrene left fourth and fifth toes, diabetic, dyslipidemic, hypertension, coronary artery disease. He had a right leg angiogram 8 weeks before and had a stent put in one of his iliac arteries. And the patient came back and he said, I'm having pain in my toes, the bottom, the fourth and fifth toes. He was a smoker and he had palpable femoral pulses and popliteal pulses, non-palpable dorsal pedal pulse. And he presented to me like this. And Shelley, this was your case. So what do you think as a podiatrist when you see this, this issue?
I mean, I see dead tissue that needs to come off. But at the same time, if the patient is stable, then I need to make sure that they have enough vascular flow coming down to that area. So if I go in and take off those toes, I'm not creating more damage. And so I think that's where it's important to work with the vascular team, because if the patient's stable and I see something like this, sure, I need to get an MRI and see how bad the disease goes back. But if I touch that and they don't have enough flow, then that's just going to create further damage and a higher up amputation.
Gotcha. So that's what we did. We did ultrasound testing. And what we found was an ABI of 1, and he had triphasic normal waveforms all the way down into the foot. Digital pressure was 75. That's all good. That's all normal. Anything over 40 of a toe pressure should heal. When we looked at his acceleration times, they were all normal, class 1 perfusion. This is normal. This ultrasound is normal, except for the anterior tibial artery had a lesion. And we thought it would be about 50 to 75% blocked from the ultrasound report. But when we look at his fourth and fifth toes, as a vascular surgeon, I'm thinking this is probably a posterior circulation problem. This is probably a posterior tibial or lateral plantar problem. And we didn't really see that on ultrasound. And so I think from what you're telling me and from what I'm seeing here, I'm going to have to believe the patient. The patient has gangrene and we don't have a good answer for that. So if the test is normal, we can't just live with that. We have to move forward to angiogram. And so that's what we did. And what we found at the angiogram was an 80% lesion in the anterior tibial, but we also found an 80% lesion and 95% lesion of the lateral plantar artery. And the lateral plantar artery will go to the fourth and fifth toes, into that region of the foot. So what we did was we took that 90% lesion and cleaned that out with a I call it the Roto-Rooter. It's like a Pac-Man. It removes the plaque from that artery, and then we did an angioplasty. But we had to look down into the lateral plantar artery, the foot arteries. And I would say that about 15 to 20% of the time when I'm working on people to save a leg, we're going to be below ankle therapy. And so here is that red line. Those red lines are to where the lateral plantar is. I think my techs were fooled by the medial plantar, which is fairly dominant right here. But the lateral plantar gives blood directly to that fourth and fifth toes. And so we had to reconstruct that vessel to actually improve the flow to that area and stabilize the foot. So Shelby, tell me a little bit after surgery, what do you think about and what do you do?
Sure. So once you were able to get the flow down there, I was able to go in and amputate both of those toes at the metatarsal phalangeal joint. And he had a little bit of delayed wound healing, but eventually we got that healed. The interesting thing with this is that each week that he would come in to check and see if we were able to transition him to regular shoes, his pain would just go away significantly with each week, and more blood flow was coming down to the area. It was interesting to see the progression of this and just the entire foot overall. It went from me barely even able to touch him while I was taking out his sutures to where he can wear a normal shoe, he can walk around without pain now, and he doesn't have any gangrene or any issues going further.
Yeah, I've called it before like the perfect storm. It's just a disaster, and until you get the perfusion and the dead tissue off and give the patient a chance to heal, then things can start to turn around. And I think that's what happened for him. So his rest pain resolved, and at 5 weeks, we can see the wound's actually healing pretty well, and then you continue to do therapy. So this next case is, we'll talk about the timing of foot surgery, and we'll move through it pretty quick. Dr. Lou from Winchester sent this patient to me, 65-year-old white male presenting to the ED with gangrene and cellulitis of the left great toe. And he had a history of heart failure and diabetes, dyslipidemia. He was a smoker, but quit 40 years ago, really. Palpable femoral pulse, popliteal pulse, but non-palpable pedal pulses. And so, Sam, this one's yours. This patient presents with that image. What are your thoughts in this particular case?
Well, the main thing is you want to just decide the urgency of this. There's the clinical classification for the severity of a diabetic foot ulcer. There's one called PETIS, which basically we're looking at perfusion, you're looking at the extent of infection, the depth of it, and sensations. Now, with this, if there's no major concern for a deeper abscess or wet gangrene, you'd want to make sure that you get a multidisciplinary approach for this and get vascular on board right away. The concern would be that if I had gone ahead and, let's say, amputated this toe where there was no major sign of infection, the concern is that the tissues proximal to that can become ischemic and necrosis as well, where you would go from a simple digital amputation to a further proximal amputation and cause more disability for this patient.
Yeah, I agree. We have some time in this case, and I don't think we have an abscess. We don't have a septic patient yet, but we need to move things along. And so that's what we did. We did some testing first. ABI was 0.6, toe pressure is 25, remember, under 40, not good. And then the acceleration times were high, class 3 perfusion. This is poor perfusion. We took him to angiogram, and basically his anterior tibial and posterior tibial was 100% occluded. He survived basically through a perineal artery, the central artery. But that central artery had a critical lesion at the end. And so we used a atherectomy device to remove that and open that back up. And then we had perfusion from an anatomic variant, in this particular case, into the arteries of the foot. And so with that, I gave him some time, and we looked at the bottom of the foot here. You can start to see granulation tissue, a little bit of sloughing of skin, but if I saw that, I would give a patient more time to see if we could grow the skin back and save the toe. But what happened anteriorly is demarcation. And when that demarcated like that and the tendon was exposed, this now becomes a surgical issue. His perfusion was normal. He was back to normal perfusion. But now was the time to refer to for the great toe amputation. So at that point, we moved ahead with amputation of the toe, and his perfusion at 12 weeks was still normal, and he was doing pretty well. Any thoughts or comments about that from the team? Is that the right way to approach it?
Yeah, it's the perfect way to approach it.
I think so. We had some really good cases. Just to talk about how we talk about the multidisciplinary case planning. It really takes teamwork to do this. And when if we're talking about limb salvage for a patient with critical limb ischemia, we've got to enact the vascular interventionalist and the podiatric specialist. These are the primary people that are going to drive limb salvage. And when we talk about improved survival for this cohort of patients, we've got to get primary care involved and endocrine and deal with infection. And so this is where we're going to actually improve survival in this group. So one of my mantras is no more amputation. And I wanted to thank the panel for great thoughts on this multidisciplinary approach. Thank you very much.